The study background centers on a key challenge. Multifocal HCC is traditionally divided into multicentric occurrence and intrahepatic metastasis, but this distinction is hard to make in routine practice. Current HACC staging lumps all multifocal patterns together, ignoring their different biologies. The authors retrospectively analyzed 229 patients from National Taiwan University Hospital between 2008 and 2019. These were divided into four groups: 76 with solitary HCC, 74 with two discrete nodules, 7 with more than two nodules, and 72 with satellite nodules. They used histologic criteria from the Liver Cancer Study Group of Japan, supplemented with TERT promoter mutation analysis, and evaluated overall survival and recurrence-free survival using Kaplan-Meier and Cox regression methods. The median follow-up was about 70 months. The key findings are striking. First, patients with two discrete nodules without satellite lesions did not show a statistically significant difference in overall survival or recurrence-free survival compared with solitary HCC. The hazard ratios were 1.82 for OS and 1.58 for RFS, neither reaching statistical significance. This is a crucial finding because it suggests that having two separate nodules, which likely represents multicentric carcinogenesis, does not substantially worsen prognosis. In sharp contrast, HCC with satellite nodules showed significantly poorer outcomes. On multivariate analysis, only two factors emerged as independent adverse prognostic factors: microvascular invasion and the presence of satellite nodules. Notably, two-nodule multifocality was not an independent risk factor. This directly challenges the current AJCC staging approach, which treats all multifocal patterns identically. In conclusion, this study demonstrates that a simplified, morphology-based classification of multifocal HCC can meaningfully predict prognosis. The traditional distinction between multicentric occurrence and intrahepatic metastasis, while conceptually important, is difficult to apply in practice and fails to classify a substantial proportion of cases. The key takeaway is that two-nodule HCC without satellite lesions behaves much more favorably than satellite nodule HCC, with outcomes approaching those of solitary tumors. This has direct implications for staging. The current AJCC system treats all multifocal HCC equally, but our data suggests that separating satellite nodule cases from two-nodule cases could significantly improve risk stratification and help guide more individualized treatment decisions. Of course, limitations include the single-center design and the very small number of patients with more than two nodules. Future multicenter validation studies are essential to confirm these findings and potentially reform the staging framework for multifocal HCC.